Michael has advanced clear cell kidney cancer. He presented with metastatic disease, as I remember. Nowadays I quote patients' median survivals of about 5 years. Those are the numbers from the Ipi-Nivo trial, which now has 5 years of follow-up. That's a median, of course. So unfortunately for some patients, it's shorter than that. And for other patients will be cured and it'll be much longer. So there's a wide range, but it's about 5 years. I think it went fine. Anytime I'm not giving bad news is a good day, So obviously we'd like to see things shrink more and more. But generally with TKIs, as you may know, the first scan or so, and then things pretty much are stable. So now it's just a matter of length of stability. He got Ipi-Nivo before we met. I think he came to me, when he was progressing on that or towards the end. And I think I don't remember what trials we had open at the time, but I don't know what we had. And also his toxicity. Most trials will require resolution of toxicity from prior therapy, which he's almost never going to have. So that might have disqualified him as well. It would have been better if he didn't start with Ipi-Nivo because he has disabling chronic neurotoxicity from that and didn't respond. So he had the worst of both worlds. You don't know that heading into it, of course, but in retrospect, he would have been better served by not getting that. I think it's just managing his lingering toxicity from Ipi-Nivo and then having acute toxicities of TKI on top of that. So that's the biggest day-to-day, week-to-week challenge. His disease challenges are just that, the cabozantinib's not curative, so he will need other treatment. So we'll squeeze as much as possible out of it, but at some point we'll have to try something else, and hopefully we have new and better drugs by then. Ten years ago, it was just TKIs. It was a sequential TKI monotherapy, which is really what he's been getting recently. So that's not that different. The big difference for him, and again, I'm not sure this is a good thing, is that immunotherapy now exists. It didn't happen to help him and happened to give him toxicity. So for an average patient, you'd say that's a very good thing. And you're more likely to respond and live longer and potentially be cured. For him personally, I don't know that his outlook is that different, because he ends up getting the same drugs we had 10 years ago, basically, But in general, there's no question there's many more options. And there's more options for him. There's other TKIs that have been improved and more trials. And so you'd rather have more options than less, of course, even though practically I think for him, it's kind of the treatments that have worked for him were pretty much here 10 years ago. Certainly axitinib would have been improved about 10 or so years ago, maybe not Cabo, but it came along shortly thereafter. So that's just him in particular, though. What's exciting in kidney cancer, I would say maybe just two things come to mind. Biomarkers, which we don't have any reliable biomarkers, and there are always promising things, but we're now starting to prospectively test them. And, as we all realize, if we could match individual patients to individual treatments, we'd be doing a whole lot better. So I think, in the next 3 to 5 years, if we could develop something clinically useful, I think that would be a major advance. And then the other category would, as I mentioned, just drugs with new mechanisms. We need drugs that attack metabolic pathways or other immune pathways or something else besides just VEGF and, that pathway and besides just PD-1. And some of those drugs are entering, clinical trials now. So I couldn't necessarily point to specifics per se, but if you say what's the other main area where we can make advances, because there's a whole group of patients who aren't benefiting from either of the classes of drugs we have, and they need something else. We just need to find it.